advantage of a peripheral blood stem cell in a malignancy is its graft versus disease effect, and the biggest disadvantage of a peripheral blood stem cell harvest in a non-malignant one is its increased risk of graft versus host disease, either acute or chronic. And that's the biggest difference which made the long-term survival in aplastic and thalassaemics slightly bit less. On the other hand, the usage of peripheral blood stem cell for even conditions like aplastic anemia is just the ease of use for a donor. There are, even in Western world where there is an unrelated donor, donors prefer a peripheral blood stem cell. They don't want to get admitted, they don't want to receive a general anesthetic. But I mean, if a donor is motivated enough to donate a bone marrow harvest, I think it would be extremely useful in patients like aplastics and other things. The other problem with, particularly in India, is about bone marrow harvest is that bone marrow harvest becomes difficult to use in ABO mismatch. Major mismatches are difficult to do simply because we can, I'm sure, I don't know whether Dr. Revadaraj is still here, but there she is. Major ABO mismatch on a bone marrow harvest is quite tricky. I mean, you have to red cell reduce, and I'm slightly nervous about red cell reduction on a harvest product. If it's from an older kid to a younger kid, it's easier to do. If it's from a bigger donor to a smaller donor, it's easier to do. You can do red cell reduction, still have adequate product and other things. I'm slightly worried about losing more stem cells on the red cell reduction and our processing of the bone marrow during just before the reinfusions. That's one thing. And in malignancies, you can reduce the T cell content by T cell reduction. You can have DLIs as a graded and increase in DLIs if you do a peripheral blood stem cell harvest. So there are advantages for both peripheral blood stem cells and stem cells from unmanipulated bone marrow. But for autologous transplant, bone marrow harvest is all done, dusted. There is very little bone marrow harvest. There are people who still do very rarely for acute promyelocytic leukemia, harvest bone marrow stem cells, concerns about CD34 contamination, peripheral blood stem cells and all those things. But as I said, in an autologous transplant, peripheral bloods have all been the choice.
Any other questions?
Sir, this HPSC in the Sysmex and CD34 count, how much is the CD percentage variation, or because that is still a research parameter in that equipment?
As I said, I mean, that still is a very, very early. I mean, if you ask any of the company persons, one of the selling points of them in selling those machines is the HPCs and the other additional channels which they promote. It's extremely expensive. This is just a resource poor, or if you are roughly want to guess, our Kishore can show you all the CV variant graphs and other things if you wanted in his paper itself. But our data shows that the HPC can be reliably used when it is more than 25 on a peripheral blood, and then the CD34 estimation in the subsequent harvest days has how many was it? At least matched in around 85 to 90%. A successful CD34 harvest in an HPC of more than 25 in around 90% of the people.
But when we tried correlating it, it was first time we got the machine about 5 years back, and that time it wasn't correlating. It was almost, the ratio is 1:2. But by the time the machine was out, so we couldn't continue it. But that time we did it about 6 cases. It wasn't correlating.
It wasn't. The total white cell count and the total nucleated count has been completely inappropriate. We have tried the total white cell count and the total nucleated count. They haven't got any correlation. this is, I can't say that this is the only thing which you should decide on all those things. I mean, if you have a patient who has got an appropriate day HPC in a bloodstream, I think they will mobilize. And unfortunately, we mobilize most of these patients with chemo GCSF or Pleureximer GCSF. So inherently, they are extremely good mobilizing agents. So we had a successful harvest, and then they say that we retrospectively put them due to the HPC in the one. But I don't think that scientifically you can say that I am going to put the patient on this, but it gives you a rough idea. Say if it is less than 10, it's very unlikely. Rather than a positive predictive value, it definitely correlates very, very well with a negative correlate. If it is less than 10, it's very, very, very unlikely that you will mobilize those stem cells. So it gives you a day where you don't want to do, rather than when you want to do.
I think we are running
Yes.
out of time. Maybe the last question.
In cryo missing, what is the ratio of missing this DMSO and stem cells, sir? And what is the rationale of adding albumin in cryopreservation?
I mean, I've got my bone marrow technician here as well, who does all these things. We only see the guidelines and he does all of those things. We use 1 in 2, is it? Huh? He is the man to ask.
Ismail, I will give you the detailed protocol.
Yes.
I think we can move on to the next session.
I think
Okay.
so.
Yes.
Thank you.
Yeah, excellent talk, Dr. Serian. It's a good start for this session of today's topic. And we'll go on to the next topic by Dr. Anupam Chakrapani, who's going to talk on lymphoma autograft beyond beam. He is specialized in stem cell transplant training at MD Anderson Cancer Center and consultant hematology and program coordinator for BMT, Department of Hematology and BMT at Apollo Clinicals Hospital now, and he was a senior consultant at Tata Medical Center, Kolkata earlier. Dr. Anupam.
Good morning. Thank you, Chairperson, for the kind introduction. And it's great, Dr. Kishore, that you have arranged this meeting. And thank you, BIJU, sir, for taking this initiative, because this ISCTR meeting which we attend is basically as an invited, not for the students. So it is always good that the newcomers should understand what is transplant and they should develop some interest in that. So my talk was given lymphoma autograft beyond beam. So shall I talk on beam or beyond beam? So the audience here is more of the students. So I thought I'll talk a little bit about beam and then what is the next development and research is going on. So as a transplant physician, when we see a patient, our situation is like this. So there are so many protocols which is available and which one to choose. So we are confused and sometimes we call our colleague, friends, seniors. So sir, we have this kind of situation, what shall I do? So, but still, today the beam, that is carmustine, etoposide, cytarabine and melphalan combination. This is the standard protocol beam. This is the standard of care. And but if you see the beam, as per the literature, the mortality rate is 3.5%. And if you go to any center in West, where I worked for a month in MD Anderson also, the people, those who are not getting eligible for any protocol, they were taken for beam as they call it as a standard of care. For today also, it is standard of care, but not in every situation. So why this question comes? Why we need a new protocol? Why? Because first chance is the best chance for any patient. So we want to give the best to the patient for his better survival. We want always to reduce the toxicity of any regimen. So whatever the toxicity which we are facing with the beam, we want to reduce that. We want to reduce the transplant-related mortality even below 3 to 5%. And we want to improve the overall survival and progression-free survival, especially in the high-risk patients. And sometimes the unavailability of the drugs. So we are familiar with the beam protocol, the drugs, but sometimes you see the BCNU is not available. Many times it has happened. So what next protocol we can use should have an understanding on that. And some special indication like disease-wise indication. So can we use straight away beam protocol to all Hodgkin's and all subtype of non-Hodgkin's lymphoma? We don't know. So from where this concept of autologous transplant has come up. This is the landmark paper published in 1995 called Parma Trials. 109 patients who responded to 2 cycles of DAF chemotherapy were randomized by giving further 4 cycles of chemotherapy versus autologous stem cell transplant. And if you see, there is a significant difference, the patients who got transplantation versus who did not get transplantation, both in event-free survival as well as overall survival. So in the pre-rituximab era, it was clearly established that autologous transplant has a role in terms of relapse non-Hodgkin's or Hodgkin's lymphoma. In the rituximab era, the same study was one study was conducted with this landmark paper, that is Coral study. So basically, this study was a double randomization where they tried to understand what is the best salvage regimen for a relapsed lymphoma. So one arm got RDAP, one arm got RICE, and once they achieved the remission, they were taken for autologous transplantation. And second randomization, they were given a maintenance rituximab for 2 years. So second randomization I will not discuss. So here what happens, if you see, the patient who underwent autologous transplantation in this study has a 3-year progression-free survival of around 53%. But if you see the poor risk patients, so the poor risk means those who relapsed early, means less than 1 year of remission, prior rituximab, their progression-free survival is only 23%. So in the high-risk patients, this regimen or this protocol is not very convincing, and we need a better protocol. But in the high-risk patient here, it clearly says that in high-risk patient, if you do a transplant, the survival is, progression-free survival is around 40% as compared to around only 14% those who don't opt for any salvage autologous transplant. So this paper clearly says that if you are dealing with any relapse Hodgkin's or non-Hodgkin's lymphoma, and if you are planning for a salvage chemotherapy, it should be consolidated by autologous transplantation. It should not be left like chemotherapy, remission, and then wait and watch. No, he has to be consolidated by some sort of transplant, either autologous or allogenic. Another paper on beam chemotherapy autologous transplantation, where they try to see the efficacy, toxicity, and prognostic factors. And here the group of patients, if you can see, the low-grade lymphoma, intermediate-grade lymphoma, and high-grade lymphoma, Hodgkin's disease. So all group of non-Hodgkin's and Hodgkin's lymphoma were taken. And I'll just try your attention here. What is the advantage of doing a transplant in a relapse or CR1 patients? So if you see, those who are in first CR, 49 patients of both non-Hodgkin and Hodgkin's, where CR in 46. More than those who are having a more than of second CR, 37, 35 patients achieve CR, first PR. So this group, if you see, those who are having a first partial remission, sensitive disease or resistant disease, the chances of achieving a CR post-transplantation with beam protocol is not very good. So if you see in the resistant cases, out of 15 patients, only 3 patients achieve complete remissions. So complete remission by this standard beam protocol. So that where we need some protocol which can be useful for, especially for this refractory diseases. So as I told you, beam is still the gold standard for the autologous transplantation, but whether it is a good conditioning regimen for high risk diseases, we don't know. So with that background, I'll take you to what are the modification the transplanter has tried in past, and now they are trying to improve the results in the relapse refractory setting. So as per the total body irradiation based protocol, in the previous years, like in 1990, there was most of the protocol they use high dose radiotherapy, but gradually they able to understand that TBI is not a good conditioning regimen, and lot of constraints are there in a lymphoma patient, because these patients have previously received radiotherapy for the bulky disease. They have already, some areas has been irradiated previously, so you cannot give total body irradiation. Chances, later on they found that the chances of secondary malignancy, bone marrow dysplasia incidence is very high, those who are getting TBI-based regimen. So the most transplant centers and groups have moved away from TBI-based conditioning regimens, and now they are focusing on chemotherapy-based regimens. So autotransplant in lymphoma BEAM. So BEAM stands for, as I told you, BCNU, etoposide, Ara-C and melphalan. So what are the modifications the transplanter has tried in past? So one study, they removed the BCNU and they gave only EAM in a different dose. I will show you the studies. BCNU replaced by lomustine, that is CCNU. Melphalan is replaced by high-dose cyclophosphamide. BCNU is replaced by bendamustine. BCNU is replaced by fluoromustine, and in some studies, BCNU is replaced by thiotepa. So transplanter has tried various permutation and combination in the standard BEAM protocol, and in certain situations, those who are CD20 positive lymphomas and those who are T-cell lymphomas, the transplanter has tried adding rituximab, bortezomib, or some radioimmunotherapy to the backbone of BEAM protocol. So first, EAM protocol is a new conditioning